Bismillahirrahmanirrahim. Uh, so, as we were discussing the retinal detachment, and we discussed it that there are different types of retinal detachment, and that is the rhegmatogenous retinal detachment, tractional retinal detachment, and exudative retinal detachment, or it can be combined traction and rhegmatogenous retinal detachment. I told you people that the rhegma means break. Whenever there is a break in the retina, and because of that break, if the retina is detached, that is called rhegmatogenous retinal detachment. If the retinal detachment is because of the traction component, like in proliferative diseases due to the vascular occlusion, sickling retinopathies, retinopathy of prematurity, or because of the most common cause is diabetic retinopathy, because of these tractional forces, if the retina gets detached, then it is tractional retinal detachment. The third type is the exudative retinal detachment. Is an exudative retinal detachment, there will be exudation of fluid from the choroidal side into the subretinal space because the RPE cannot perform its function properly. Usually, the RPE is acting as a pump mechanism, and it is not allowing the fluid from the choroidal vessels to enter into the subretinal space between the neurosensory retina and the retinal pigment epithelium, which is the potential site for the retinal detachment. But when the RPE function is compromised because of any pathology, because of the inflammation, tumors, or any other diseases, so the RPE cannot perform its function normally, and the fluid will get entry into the subretinal space, leading to the retinal detachment. If it is because of the exudation of fluid, the retina gets detached. It is called exudative retinal detachment, and an exudative retinal detachment, there is no break in the retina. So it's only because of the exudation of fluid, and how you will know that the patient is having exudative retinal detachment or tractional retinal detachment. We discussed last time that in traction retinal, and rhegmatogenous retinal detachment, there will be break in the retina. Whenever there is break in the retina, the retinal pigment epithelial cells are exposed to the vitreous. And you can see these retinal pigment epithelial cells are brown cells, and you can see the brown cells within the vitreous cavity. Whenever you see the brown cells within the vitreous cavity, you must suspect that there is some break in the retina because these brown cells are only coming from the retinal pigment epithelium, and the retinal pigment epithelium can only approach the vitreous cavity if there is a break in the neurosensory retina. So whenever you see brown cells in the vitreous, it means that there is some break in the neurosensory retina, and because of that break, the retinal pigment epithelial cells are exposed and it's reached up to the vitreous cavity. If there is no break, then there should be no brown cells or retinal pigment epithelial cells within the vitreous cavity. And exudative retinal detachment, there will be no brown cells. Secondly, while examining all the periphery of the retina, you will not be able to find any break. Thirdly, there is another mechanism that is called shifting fluid test. Because if the patient is in the sitting position, the fluid will gravitate inferiorly due to the mechanism of gravity, and it will detach the inferior retina. But when you examine the patient in the lying position, then the fluid will go and put towards the posterior retina, and it will detach the posterior retina. That is the shifting fluid. The fluid will shift as per the gravity effect and the exudative retinal detachment. An exudative retinal detachment, as there is no break in the retina, so surgery is not indicated for these cases because there is no break in the retina. Surgery is indicated only if there is traction on the retina because you need to relieve the traction. If there is break in the retina, then you need to close that break. Only then the retina will be attached. Otherwise, the retina will not be able to attach if the break is open. So, an exudative retinal detachment, as there is no break in the retina, so there is no need of surgical intervention. So, we need only to treat the cause of the exudative detachment. If it's because of the inflammation, the most potent anti-inflammatory drug is the steroids, and mostly we are giving steroids to these patients. If it's because of scleritis, again, that's inflammatory condition of the sclera leading to the exudative retinal detachment. Again, we need to treat it with the steroids. If there are any tumors and the choroid, we need to treat the tumors. If it's because of the metastatic tumors to the choroid, which is the most common site in the eye for the metastasis, that is the choroid. So we need to treat that systemic tumor. If it's because of some other inflammatory conditions like panophthalmitis, like VKH syndrome, which can also lead to the serous or exudative retinal detachment, again, we need to treat it with the steroids. So the retina will be attached. From here, it is detached, and there will be the shifting fluid test will be positive in these patients. This is bullous type of retinal detachment because of the increased accumulation of fluid in this area. But you will not be able to find any traction on the retina or any break in the retina. Another type is the traction retinal detachment. There will be traction forces on the retina, and it will pull the retina towards the vitreous space. While there will be traction forces on the retina, normally there is no traction effect on the retina. The traction forces are present in the proliferative diseases like in diabetic retinopathy. What happens in diabetic retinopathy that there is ischemia of the retina. When there is ischemia, there is proliferation of the retina. The new vessels are formed. The new vessels are formed because of the ischemia of the retina. And these new vessels are very fragile. They can bleed easily. And when they bleed, the blood is going into the vitreous cavity. There is fibrosis of these new vessels. And with the passage of time, these are attached, these are growing into the vitreous cavity. And with the passage of time, it gets fibrosed. And whenever there is movement of the vitreous, there is also movement of these fibrous tissue because these fibrous tissues are attached to the retina, and it will pull the retina, leading to the traction on the retina and retinal traction, retinal detachment. Sometimes with these traction forces, there is some break found in the retina, and then it is called combined tractional rhegmatogenous retinal detachment, and that rhegma, that break is formed because of the traction. It can occur in the diabetic retinopathy. It can also be there because of the vascular occlusion, central retinal artery occlusion, branch retinal artery occlusion, vein occlusion when there is proliferation and leading to the traction forces development and retinal detachment. Similarly, there are other diseases like sickling retinopathies and children, even in Coats disease and that is the retinopathy of prematurity. Again, there is ischemia of the retina leading to the proliferation, and their proliferation then lead to the traction on the retina, leading to the traction retinal detachment. Again, you can see there are traction forces on the retina. The retina is attached, but because of these traction forces are within the vitreous cavity, the macula is fine. But you can see all these vascular arcade, the toxicity of the vessels, and these traction forces are present on the retina. It will pull the retina. You can see over here in this region and also in this region. Now, if there are so much traction on the retina, what will be the treatment? The treatment is only to relieve this traction. How we can relieve this traction? By going into the eye and performing the pars plana vitrectomy. We need to remove all this vitreous. We need to remove all these membranes. And when this vitreous and the membrane is relieved, then the retina gets attached because the traction forces has been removed. And then we perform because there is ischemia of the retina, and for the ischemia of the retina, we are going for the pan-retinal photocoagulation. That is called, when we are doing it surgically within the eye during surgical procedure, that is called endo laser, because we take the laser inside of the eye and then perform the laser. If there are traction retinal detachment, so the procedure is pars plana vitrectomy, and this is called three ports pars plana vitrectomy because three ports are formed. We already discussed one is port is for the continuous infusion. Why the infusion is needed? Because if you are cutting the vitreous from within the vitreous cavity, what will happen? It will collapse. The pressure within the eye will be lost, and the stability of and the tone of the eye will be lost, and there are increased chances of further retinal detachment because of the softening of the eye, because of the hypotony of the eye. So to maintain the normal pressure within the eye, the infusion cannula is needed, and through the infusion cannula, continuously the fluid is coming to the vitreous cavity when we are cutting the vitreous to maintain the tone of the eye. The second instrument, that is the light source, that is used for visualization of the retina, and the third instrument, that is the vitreous cutter, are different types of instruments. If we are needing, let's suppose if we are needing scissors to cut a particular area, then again we need to insert a scissor through this break, and these are all micro instruments, very small instruments. So we can change these instruments again and again, but usually these two instruments are needed all the time. One is the light source, the second one is the infusion cannula, because the tonicity of the eye is maintained to the infusion cannula, and through the light source we can visualize the retina. Now, let's suppose all the vitreous has been cutted, the retina is flattened. Now, we need to substitute the vitreous cavity with another substitute to replace this area to maintain the volume of the eye. What we are doing, we are putting gases. Gases can be inserted again through the same infusion cannula. Sometimes we need silicone oil, and the silicone oil can also be infused or injected through the infusion cannula. and then the infusion cannula is removed and these ports are stitched or closed. There are different types of vitrectomy systems nowadays available. In the past we used to do 20 gauge vitrectomy. Still in Peshawar and these areas 20 gauge vitrectomy is done, but now most of the people are shifting to 23 gauge porcelain vitrectomy and 25 gauge. Even in the foreign countries they're now doing 27 gauge vitrectomy, which the sutureless 23, 25, and 26 all are sutureless. And as the gauge is increasing, like from 23 to 25, 23 is 20 is larger than 23, then 23 is larger than 25, and 25 is larger than 27. So up to now, we are in the developed countries, they are doing 27 gauge vitrectomy. Very small instruments are used, and these incisions are not needed to be sutured. That is called suture partial vitrectomy. But why we are not using these 27 and 25 gauge? Because the instruments are very much delicate instruments are used, because they are very fine instruments and they are very much expensive. Is the gauge of the instrument increases, its durability or the working duration that is reduced, because the size of the instrument gets smaller as we are shifting from 23 to 25 and from 25 to 27. So again, if there is traction forces on the retina because of this vitreous, we need to cut this vitreous, all the vitreous from the retina. And when the vitreous is cut from the retina, the traction on the retina will be relieved and the retina will go back and will be attached. And then we will be performing the endo laser. And with the endo laser, fibrosis will be formed between the retina and the choroid, and the retina gets attached. These are the ports which are formed on the for partial vitrectomy, and usually I think I have mentioned it that how much it will be away from the limbus. And the phakic eye, if the patient is having its own intraocular lens, then it should be 4 millimeter from the limbus. This is the limbal area, 4 millimeter from the limbus. And if the patient is pseudophakic, then 3.5 millimeter from the limbus. And always remember these measurements, because it is used for all sort of entry into the posterior segment of the eye, whether we are injecting the antibiotic into the eye, we are giving anti-VEGF injections into the eye, and if we are performing the partial vitrectomy, and all these things we need to go through the pars plana, that is 3.5 millimeter in pseudophakic patients and 4 millimeter in phakic patients. Why 4 millimeter from the phakic patients? Not to touch the periphery of the lens, because when we touch the periphery of the lens, what will happen? There will be cataract formation in the lens. So again, the light pipe is used. This is the vitreous cutter, and with this the vitreous is cutted, and when the vitreous is cutted, another port is used for the infusion to maintain the tonicity of the eye. When we cut all the vitreous and it's still the retina is attached, and if there is subretinal fluid and if there is a break in the retina, what we are doing, we put a needle inside our that is called flute needle, and we put it, bring it closer to that hole, and will drain that subretinal fluid. And in the subretinal fluid, the fluid beneath the retina, when that is drained, what will happen? The retina will get attached. Again, these are the instruments. Once again, that is used. That is the infusion cannula, light source, and the instrument. That is the cutting instruments. Are different types of other instruments we are putting in. This is the biome system, a binocular indirect ophthalmic operative system, operating microscope. This is the infusion cannula. The infusion cannula is connected with the drip, and through the drip, the fluid is coming continuously and is to maintain the tonicity of the eye. And the pressure within the eye can be changed through the height of this drip set. If we are taking it to a higher position, what will happen? The pressure inside the eye will be increased, and if you are bringing it down, the pressure inside the eye will be reduced. Again, another thing, now in the new machines, there are different types of the pressure maintaining systems are available, and with that you can maintain the pressure within the eye up to your desired pressure. So this is the infusion cannula, and then this is the cutter. With the cutter, we are cutting the vitreous, and this lens is attached. And there are different types of lenses: wide field lenses, 90 diopter lens that is attached with the biome, and the biome is again attached with the microscope. And through this lens, we are viewing the posterior segment of the eye. Now, if the vitreous is removed, what are the substituents or vitreous substitutes that we can put into the vitreous cavity? It depends. We can put silicone oil, we can put gases. There are different types of oils. The heavy oils, heavy liquid can also be put into the vitreous cavity, but usually we are not leaving the heavy liquid inside the eye. Why? Because that are retinotoxic. But in certain conditions, let's suppose if the break is inferior, if the break is inferior, what we are doing, we have to put encirclement band exterior to the eye beneath the muscles, because we are using these vitreous substitutes for tamponading effect of the retina. Let's suppose the retina is detached and you want to attach it, then there's some tamponading effect must be needed to maintain to bring the retina in closer approximation to the choroid so that the subretinal fluid is drained and the retina gets attached. Now, we discussed that we can perform it when we complete our pars plana vitrectomy. All the vitreous is removed. Now there is water inside the eye. The water is not having that much tamponading effect. Secondly, the water will sink down. When the water will sink down, what will happen superiorly? There will be no tamponading effect of the retina. Then we can put gas or silicone oil. How we will know that? When we need to put the silicone oil and when we need to put the gas or other substitutes. Now, let's suppose a patient is having chronic retinal detachment with high-grade PVR. PVR means proliferative vitreoretinopathy, and that is specific for the rheumatologist retinal detachment. Why? Because in the rheumatologist retinal detachment, there is entry of the retinal pigment epithelial cells into the vitreous cavity. There is proliferation of the glial cells, fibroblasts. It makes membrane over the surface of the retina, and then it prevents the attachment of the retina to the choroid. We need to remove all these membranes during pars plana vitrectomy. When all the membranes are removed and the patient is having complex retinal detachment or chronic retinal detachment, then we need to put silicone oil inside the eye, because the silicone oil will be giving more tamponading effect to the retina. Secondly, the silicone oil is not going to absorb and it need to be removed. So if we are putting gas in a complex retinal detachment, what will happen? The gas will be absorbed with the passage of time, because sulfur hexafluoride is used, SF6 gas is used, C2F6 is used, and C3F8 is used. Now, the SF6 is having normal air is usually absorbed within 3-4 days. SF6 is absorbed usually within 2 weeks. C2F6 is usually absorbed in 30-35 days, and C3F8 gas, all these are gases, and C3F8 gas is absorbed usually after 2 months. So if there is complex retinal detachment and we put any gas in the eye, what will happen? The gas will be absorbed with the passage of time and the tamponading effect of the retina will be lost. Secondly, let's suppose if you are putting C3F8 gas, and that is very widely used worldwide, because it is a long-acting gas, it will be there in the eye for about 2 weeks. 2 months, sorry. So, like after about 2 weeks, what will happen? There will be absorption of the gas. Even the total duration is 2 months, but there will be absorption of the gas, and with the passage of time, the bubble of the gas within the eye will be reduced. So, when the bubble of the gas within the eye is reduced, the tamponading effect will also be reduced. So we need to put silicone oil in complex retinal detachment. But if the patient is not having complex retinal detachment, it's a fresh retinal detachment, superior retinal detachment, because the silicone oil is lighter than water. The gases are also lighter in water. So they are mostly tamponading the superior retina, and the inferior, if the break is in the inferior retina, that is always very complicated cases, and usually with the passage of when we put even silicone oil, our gas is usually inferior, the retina again gets detached. So inferior break are comparatively difficult to be closed than the superior break, because the silicone oil, the gas is always having tamponading effect superiorly. Then if you are putting the silicone oil inside the eye, there are certain complications associated with silicone oil, because the patient will need another surgery for removal of the silicone oil, because the refractive index of silicone oil is more than that of water. There will be some vision will not be clear in silicone oil. Even it will not be clear with the gas, but the gas will not need a second intervention because it will be absorbed itself. But the silicone oil need to be removed, so it needs another surgery. Secondly, if the patient is phakic, the patient is having its own intraocular lens, again the silicone oil will induce cataract, and again that cataract will also be needed. Another complication of the silicone oil is with the passage of time, if the poor quality silicone oil is used, or if it is there for longer duration, what will happen? That the silicone oil will be emulsified. Emulsification means it will be broken down into smaller particles. And whenever the silicon oil are broken down into small particles, it's very difficult to remove. Like you can see, this is emulsification of the silicon oil. It is it has break down into smaller particles, and these particles are very difficult to remove. And what it will do, it will come into the anterior chamber, and the anterior chamber, because these are lighter than water, so they will go up and they will form a white. Just like hypopion. Hypopion means pus in the anterior chamber, but actually it's not pus. It's the silicon oil, because silicon oil will go superiorly, and these are the emulsified silicon oil. They are not in the form of a bubble, but multiple small bubbles. And this is also called inversus hypopion, means inverted hypopion. Hypopion usually settle down inferiorly, but it will go superiorly. And it is not the true hypopion, but it is pseudo hypopion because of the silicon oil it is formed. And actually, it's not the pus. Actually, it's the silicon oil drops. And what it will do, it will block the trabecular meshwork and anterior chamber and the fluid, the aqueous that is formed. It will be very difficult for the aqueous to be drained through the trabecular meshwork, because the meshwork will already be blocked by the emulsified silicon oil. So it's another complication of silicon oil. So let's suppose if you are putting silicon oil in an eye, if the eye is aphakic, there is no lens, what will happen? The silicon oil will block the pupil. If the aqueous is formed in the posterior segment, it will not be able to come into the anterior chamber to be drained to the trabecular meshwork. So usually we are doing iridectomy superiorly over here, so that it should be covered by the upper lid. But if we are putting silicon oil in the eye, and if we make iridectomy it over here, what will happen? That the silicon oil is going to block this iridectomy, because it will go up. It will block the pupil. It will also block the superior iridectomy. So for that purposes, whenever we are putting silicon oil in the eye, we need, and the patient is aphakic, we need to make iridectomy inferiorly, and that is called endo-iridectomy, ANDO, endo-iridectomy. And the purpose of this is because silicon oil will move up, that's lighter than water. It will cover this area, also this area, and any fluid aqueous that is formed will go inferiorly, and it will come to the anterior chamber through this endo-iridectomy, and then it will be drained. If you form an iridectomy superiorly, what will happen? It will be blocked by the silicon oil. The fluid will go inferiorly, and it will not be having any place to come into the anterior chamber, because the pupil will be blocked by the silicon oil. Superior iridectomy is also will be blocked by the silicon oil, and the fluid will not be having an access to the anterior chamber to be drained to the trabecular meshwork. Thank you very much. So it was all about the retinal detachment, different types of retinal detachment, that is rheumatologist, fractional, and exudative. The treatment of exudative retinal detachment is steroids, because that is no break is there, and the exudative retinal detachment. For the traction retinal detachment is because it's because of the traction on the retina, so we need to relieve the traction by performing the partial Amitrectomy. We can relieve the traction on the retina, and the retina will be attached. If the patient is having rheumatologist retinal detachment and the rheumatologist, there is break is there, so we need to close that break. And again, we need to do partial Amitrectomy or external surgery by by placing a plomb over the break and then performing the cryotherapy, and we can close that break. How the patient will present? Usually, the patients with the retinal detachment will present with sudden loss of vision. If the patient presents with sudden loss of vision, and you perform the visual acuity of the patient, and you know that the vision of the patient is reduced, then you need to do the pinhole test to know whether this reduced visual acuity is because of any refractive error or because of some pathology. And the retinal detachment, there will be no improvement and on the pinhole test. The next you need to examine. You need to examine the cornea. The cornea will be clear. The anterior segment will be normal. Usually there might be some predisposing condition due to the retinal detachment. Let's suppose high myopia. If the myopia is more than 6 diopter, I told you that's pathological myopia. And why it is called pathological myopia? Because different types of pathologies are associated with high myopia. If the patient is myopic and there is history of sudden loss of vision, because I told you that the most common degeneration associated with retinal detachment is the lattice degeneration. Lattice degenerations are more common in myopes. So when you examine the retina, examine the anterior segment, that will be normal. When you examine the vitreous, if it's fragmentous retinal detachment, there will be some brown cells and the vitreous, and then you need to dilate the patient, see the periphery of the retina. If there is retinal detachment, you will be able to see that retinal detachment. There will be retinal detachment will cause sudden painless loss of vision. And whenever an exam you are getting a question with a sudden loss of vision and that is painless, you must try it and the differential diagnosis, the retinal detachment as well. There will be relative afferent pupillary defect because the retina is formed by the ganglion cells and that retina is now detached, so the optic nerve function will be compromised, leading to the relative afferent pupillary defect. There will be visual field defect. Let's suppose if the inferior retina is detached and superior is still attached, so the superior vision of the patient will be good, but the inferior field, that vision is because of the superior retina will be good, but the superior vision because of the inferior retinal detachment will be lost. So there will be some visual field defect as well. And then all the steps of the examination you need to perform, and then you will know that there are brown cells in the vitreous cavity, and if you then you must find a break in the retina, and you need to break to close that break. So it's all about the retinal detachment, and we will think that whether we can go for the assessment on the retinal detachment. I will let you people know then, or we can continue with some more classes. So let's see. So thank you very much for, and it was all about the retinal detachment.